Hello and welcome everyone. My name is Dr. Medhavi Gupta. Today we'll be talking about treatment options in metastatic triple-negative breast cancer. Before we talk about the specific treatment options, let's talk a little bit about triple-negative breast cancer. So in today's time, the way we define triple-negative breast cancer is based on what it is not rather than what it is. In the world of breast cancer, we test all the tumors for 3 specific receptors: estrogen receptor, progesterone receptor, and HER2 receptor. So triple-negative breast cancers lack expression of any of these receptors. They account for approximately 15% of all breast cancers. They are more common in younger women, especially women less than 40 years of age, African American women, and patients who have BRCA mutations, especially BRCA1 mutation. These tumors have aggressive biology and therefore have a worse prognosis as compared to other breast cancer subtypes. They tend to relapse early, especially within the first 3 years, and they are more commonly associated with visceral mets. When it comes to the treatment of metastatic triple-negative breast cancer, it is important to keep few things in mind. Firstly, whether the tumor is PD-L1 positive or not. The reason this information is important is because PD-L1 positivity determines whether the patient is a candidate for immunotherapy or not. Secondly, we see whether the patients have either germline BRCA1 or BRCA2 mutations, because if the patients have either of those 2 mutations, they could get a class of drugs called as PARP inhibitors. Thirdly, if the patients previously had localized triple-negative breast cancer, it is important to see what were the previous lines of therapies that the patients got, because that will determine the treatment in the metastatic setting. Last but not the least, we see what is the functional status of the patient, because that can help us in estimating what therapies the patients can handle or not. Historically, the treatment options for metastatic triple-negative breast cancer were very limited. But in the last few years, we saw addition of several new drugs. To talk about those agents, we have a very special guest today, Dr. Aditya Bardai. Dr. Bardai is a breast medical oncologist at Massachusetts General Hospital. He is also an assistant professor with the Harvard Medical School. Dr. Bardai, thank you for joining us today.
Thank you for having me.
So let's start the conversation by talking about immunotherapies. So in March 2019, FDA approved an immunotherapy agent called as atezolizumab for patients who had metastatic triple-negative breast cancer and were PD-L1 positive based on the Ventana assay. Dr. Bardai, could you please walk us through the data in Impassion 130 clinical trial?
Yeah, absolutely. Impassion 130 trial was a landmark trial in the field of oncology, breast oncology in particular, because it introduced immunotherapy for patients with metastatic triple-negative breast cancer. It was a fairly straightforward trial. It was designed as first-line therapy for patients with metastatic triple-negative breast cancer or inoperable locally advanced triple-negative breast cancer. So as this was a first-line trial, patients could not have received any prior therapies for metastatic disease. Patients were randomized to receive standard chemotherapy, which was nab-paclitaxel in this clinical trial, with atezolizumab versus nab-paclitaxel plus placebo, 1:1 randomization. The primary endpoint was progression-free survival, as well as overall survival in the full population, as well as the PD-L1 subgroup. In terms of the results, this was a positive trial, particularly for the PD-L1 positive subgroups. In the PD-L1 positive metastatic triple-negative breast cancer, the overall survival with atezo was 25 months, as opposed to 18 months with nab-paclitaxel plus placebo. So this was both statistically significant and clinically meaningful. And based on these results, FDA granted accelerated approval to atezo plus nab-paclitaxel for PD-L1 positive metastatic triple-negative breast cancer. The PD-L1 positivity was defined based on the Ventana assay, and the cutoff was 1% or higher.
As Dr. Bardai mentioned, shortly after the trial, it changed the treatment paradigm for patients who had PD-L1 positive metastatic triple negative breast cancer. But after atezolizumab, there was an addition of another immunotherapy agent known as pembrolizumab. This agent was approved in November 2020 based on Keynote 355 trial. Dr. Bardai, could you please guide us through the data again?
Yeah, Keynote 355 trial was a similar trial to Impassion 130. There were three major differences. The first being the immunotherapy that was studied in this trial. It was Pembro as opposed to Atezo. The second was the chemotherapy backbone. The chemotherapy backbone in Keynote 355 essentially was pretty flexible. You could use nab-paclitaxel, paclitaxel, or a platinum. So there was more choices in terms of use of chemotherapy agent. And third is that this trial allowed patients who had disease progression after 6 months of neoadjuvant adjuvant therapy, which was a bit different from the Impassion 130 trial. So the trial randomized patients with metastatic triple negative breast cancer 2:1 to Pembro plus chemotherapy versus placebo plus chemotherapy. Similar to Impassion 130, this was also a first-line study. In terms of results, similar to Impassion 130, this trial was also positive for the PD-L1 positive subgroup. In patients with PD-L1 positive metastatic triple negative breast cancer, the progression-free survival was higher with Pembro plus chemotherapy as opposed to chemotherapy plus placebo. The hazard ratio was 0.65. We've not seen the overall survival results yet. One thing to note is that the definition of PD-L1 positivity was different in this trial as opposed to Impassion 130. The cutoff was 10 or higher, and this was based on what is called CPS, which is a combined score that not only looks at PD-L1 in the tumor microenvironment, but also the tumor. So it's much more comprehensive than the Ventana assay that was used in Impassion 130.
Before we move on to the next class of drugs, Dr. Bardai, could you please tell us what are the common side effects of immunotherapy agents?
Yeah, immunotherapy agents are a bit unique in terms of the side effects. They tend to cause what are called IRAEs, or immunotherapy-related adverse events. And essentially, it's like flare of an autoimmune phenomena. You have the, you can have side effects that can range from colitis, to hepatitis, to endocrinopathies like thyroiditis, or even diabetes mellitus, and serious side effects such as pneumonitis or encephalitis. So essentially, any organ can be affected with immunotherapy. The key is early recognition and institution of steroids. In terms of the most common side effect, the most common side effects include colitis and thyroiditis. So it is important to monitor for the thyroid hormone when patients are receiving immunotherapy. And if patients have side effects like shortness of breath or diarrhea, or if the liver enzymes are going up, that needs to be recognized, and patients promptly need to start steroids.
It is really exciting to know that we don't just have one immunotherapy option, but rather two now. You mentioned that with Pembro, we do not have the overall survival data yet, but the progression-free survival looks very promising. My question to you is, when a patient presents, how do you choose between the two immunotherapy options? You also mentioned that they were approved based on two different assays. What are some of the other factors you keep in mind before deciding?
Yeah, I guess it's good to have options. We have two options in terms of immunotherapy for our patients with metastatic triple negative breast cancer. The factors include chemotherapy choice. If one were to use nab-paclitaxel, I would probably go with atezolizumab because we have both progression-free survival and overall survival data. Someone with de novo metastatic triple negative breast cancer who's not received any therapy in the past, probably that would be something to consider. On the other hand, if a patient has received neoadjuvant or adjuvant ACT and then had disease recurrence, and I'm more interested in using a platinum as a chemotherapy backbone, then I would go with pembrolizumab, given the Keynote 355 trial data, which showed that you can use a platinum in combination with pembrolizumab. In terms of the assay, I would link the assay with the therapy. So if I'm interested in Atezo potentially, then I would use the Ventana assay to look for PD-L1 positivity. On the other hand, if I'm interested in Pembro, then I would use CPS. Some institutions send both assays, and if you're sending both assays and one is positive, then I would use the therapy that's linked to that assay.
That makes sense. Thank you for answering that.